Hi everyone, and thank you for having us. So we're here to talk about the human and machine. How do we envisage working together to provide care? And it's great to be here. Really excited to talk about this topic. I think, as the last panel showed, it's a very hot topic. I think people have their views. I would encourage everyone to think about your view on this very hot topic. And it's a serious topic. You know, we actually, as a panel, asked to change the name of this because it was originally called Human versus Machine. And I started to think, you know, is it a versus or is it an and? Because I think that versus starts to create this debate, and I think it's a really healthy debate. But actually, it's a very serious debate as well. You know, I know radiologists that are very excited about the future of AI because it's going to help their role. But I also have friends who didn't apply for radiology training in the UK because they're scared of job loss and things like that. So it's a really important topic. I think it's important that we debate, and I think it's important that we reflect on both the risks and the benefits. But I'm really excited to be joined by some great people in the industry that have experiences in AI. So I'm 𝐂𝐞𝐝. I'm a doctor by background in the UK, but also more recently a co-founder of Blum Health, which is a software-based company. And we have built a series of solutions, but have started to explore AI in the last 12 months or so. So we're really starting to feel, you know, how hot this is as a tool for clinical care. So I'm actually going to allow everyone to introduce themselves. So if we could start off with Thomas, just 30 seconds in true tech style.
Yes, so Thomas is my name. I'm French, working for 𝐂𝐨𝐬𝐬𝐻𝐿. I'm head of healthcare there, based in Berlin. What we're doing is basically helping healthcare organizations build, design, define, and build new digital business model in healthcare.
Thanks, Thomas.
Thank you. So my name is Abiola Ayilara. I'm from Nigeria, and I'm the CEO of �W𝐞𝐝 Assistant Limited. What we do is we connect caregivers to clients using their geographic location to map them to care and support. So our major services include getting support for clients with dementia, elderly, mental health problems, children with learning disability, and much more. Thank you.
Hi everyone, my name's
Mic swap.
Testing.
Let's have a mic swap.
Oh no, it's working now. Hi everyone, my name's Dr. Giles Morrison. I'm a clinical UX strategist. I'm also the director of the Clinical UX Association, which is the world's leading authority on clinical UX, and also a lead instructor for the Clinical UX Academy, which trains out people to do what I do, which is the design of digital physical products in healthcare and healthcare services, emphasizing on research and design of that to improve the usability, accessibility of those tools and products and services.
Hello. My name is Max. I'm from Russia. I've been in software development for 20 years almost, and I've made a project which is also at Expo, if you want to. So the project is about calculating best pharmacotherapy for cancer patients. Thank you.
Thanks, Max. It's a great privilege to be on this panel with you all today. I think we can safely say that there's a real range of professional skills, experiences within different markets globally as well, which is really exciting. So I really want to kick off by talking about this idea around AI and humans working together, and whether it's an evolution or a revolution. And this was something that Thomas raised when we met before the panel. And it's really quite interesting, actually, looking at how both developed countries and developing countries will use AI in different ways. And I think how that human interaction works with AI is quite interesting. So, Thomas, did you want to say a few things?
Yeah, basically to this question, there will be, in our opinion, two speeds. So the first is for established healthcare system. So you're talking about Western Europe, where you have already very proficient healthcare system with high access and working very well. And basically for those countries, you will have more an evolution. You will have the physician and AI working along together, but AI really supporting the physician in his decision, and the physician having, in the end, the final call. That's why that will be the evolution scenario. And then it's kind of a beautiful story in my opinion, but for countries right now which are kind of lagging behind with less access, that are not as efficient, where people don't have access to care, if these countries take this opportunity of AI and define policies that enable AI to scale and AI to make basically decisions. So we have this example of the radiologist, which is always a good one. If you don't have enough radiologists, you could use AI to make clinical decisions and basically scale and make people access to healthcare much more easily. And in this case, you will have those countries doing kind of a leapfrog and being more advanced than the countries that are considered today as the leaders. And this innovation will be brought back to these established healthcare system and developed economies, which is, in my opinion, a kind of beautiful story.
Thanks, Thomas. I mean, it's a really interesting concept because certainly what we're delving into here is now health inequality, and actually how do we support people in both developing countries and developed countries, and what are the differences there? And I really like the idea that actually proving how AI and humans can interact together in developing countries may actually teach us something in the developed countries, which is a really interesting concept. And I think that's something that certainly being someone that tries to innovate in the UK, often we think, is there somewhere else that we can implement this, demonstrate value, and actually say, look what we're doing. You should really get involved. So I really like that concept across the MedTech field, but particularly in AI, supporting care provision en masse through the support of machine is quite an interesting and quite a new experience. I guess just on that point, Abiola, having trained in the UK and now living in Nigeria, how do you think that we can sort of learn from the varying experiences in different cultures, different countries, different economic statuses?
Thank you. So with my experience in the UK and then back in Nigeria, I know there is a dearth, like a gap in health inequalities. Now, for example, a recent survey showed that 94% of Nigerians are interested in using AI. However, in the educational system, especially within healthcare, there is about 20 to 30% of people that are even aware of health informatics. So in Nigeria, the problem or the challenges we have currently is the adoption of health informatics in healthcare. Now, don't get me wrong, most hospitals and private clinics, they use electronic health records. However, they are all in silos, so there is no interoperability, and it's a major challenge. And with myself, so what we did was that, first of all, I thought, if you want someone to use a system, you need to let them know how it's been done. So in order to do that, we thought about creating more awareness about early adoption of health informatics in respect to AI, machine learning, and the likes. So we did that by creating a nurse digital transformation program, just to make more nurses aware that there are other specialties you can consider. And with that, we now thought about, okay, what else can we do? So with My Care Assistant, it's just, trying to help people to see that it is possible to use AI as a support tool in the management of patient care, and on the side, also helping to improve the education and awareness of the nurses and the medical profession in Nigeria.
Thank you, Abiola. I think, you're totally right. I think that whole thing around education, training people, how we're going to interact with artificial intelligence, I think it comes back to trust. And I think trust is ultimately the bottom line. How is someone going to trust something if they don't know how to use it, they don't know what it's going to do, especially if it's with sensitive things such as patient care, patient identifiable data. And I think all of these things, and we owe it to our patients to actually support them and be totally transparent and authentic in the way that we propose a solution, whether it be technical, in any of the novel technologies that we may use to provide care. I think that trust and transparency is key, not just with patients, but actually with fellow staff as well. I think one of my experiences is that staff only trust something if they know that it's robust, it's safe, and is actually going to do what you say it's going to do. Just on that point, Giles, I know trust and AI was something that you were quite passionate about and still are. What do you think on that matter?
Yeah, so there's quite a lot here to discuss with this topic, and it has been touched upon with the previous panel, I think. The key thing with trust as a clinical UX professional is that if I'm trying to support someone in performing a task relating to health, so it's a patient trying to improve their health, it's a clinician trying to provide healthcare services, whatever tool that they're using, they've got to trust that it can do the job. Otherwise, why are they going to choose to use it? In fact, sometimes that trust is what allows you to be fully open to using a product, not just for the first time, but through its use. So if we liken it to actually seeing a clinician, if you don't trust that clinician and they're talking about your sex history, actually you're not going to open up. I've been there on ward rounds where there's a patient who's on a respiratory ward and they literally are a smoker. That's why they've got lung pathology, lung problems. And the medical student didn't get that trust from the patient, so they never spoke up about what they were actually facing. So trust is really important for people to actually use a product properly and fully. And so for me, as mentioned before, as a clinical UX professional, I need to think, well, what is going to make someone have reduced trust in this tool, in this technology? And specifically in the case of AI, it's often the times that you can't have a human interaction with it when it's pretending to be human. So it's so much better when actually, if it's clearly not human, make it clear to the user that it's not a human being. That actually increases trust because you understand what are the limitations of that solution. You don't have such high expectations that suddenly get reduced. So I think it's getting products that are utilizing AI to see how they fit into a wider ecosystem of solutions, of processes that ultimately help someone perform that task. So, for example, we talk about AI being able to diagnose patients. Well, that's one part of actually the whole task of how do I get this person healthier? Like they've got a problem. Part of it is the diagnosis. The other part is treatment. The other part is actually even the patient recognizing that this is a serious problem or being reassured that what they fear is a really big problem actually isn't so big at all. And AI in isolation probably isn't going to solve that problem. This is the interactions with other human beings or even the individual patient being able to reflect on their situation. So that trust part is very, very important with AI, but that can be enhanced when we think about, well, what tasks are we trying to achieve with it? And also, what else can we be using with that AI tool to actually support whatever the patient or the clinician is trying to achieve?
Thanks, Giles. I agree. I think that there's many ways that we can use AI. Nate on the previous panel mentioned about actually getting to that end user, getting to that human through whichever means possible. If you go to customer services and you want to speak to a human, you get through the chatbot to talk to the human. And I think this is very much the same, is that those kind of supportive tools enable us to get to that end result. And that's blanket. So if you think about diagnostics in AI, recognizing malignancies in chest x-rays and things like this, actually, you need to be able to have trust in that, but also there needs to be accountability. And you're not going to be able to hold a machine accountable for its actions. Ultimately, it needs to come back to a human, and I'm sure medico-legal would never let that go away, because as clinicians, we have a duty of care, and that always comes back to the human. But you're totally right. Having that support, that raft, as I like to call it, that takes that person there in the most efficient way. And I think this comes back to my care assistant, Abiola's project that she's been working on, is about actually leveraging AI to connect patient and clinician. Going back to so one of the parts of trust, I think, is that AI really does gain its trust through working at scale. It needs to prove itself over time and gain that traction, gain that trust over time. I think, Max, your experience at 𝐿𝐿𝐼, you mentioned about actually that working at scale is something that AI enables you to do more effectively to be able to provide care. Is that right?
Yeah. I think that we, as a humanity, have all a long journey talking about medicine. Medicine was things like we pray for, Then it was a magic in the Middle Ages. 20th centuries, it became a science. And now, as Brian mentioned at the previous panel, it's kind of a service. And we, as the patients, we want a service. And the service, the standards of this service are too high. We want it 24 hours, 7 days, 365 days. We want this service with updates, with new releases, and we want this service at the moment. So in order to do this service, we need to have resources. And even dealing with such diseases like oncology, cancer, there is always a thing about resources. What resources, what pharmacology resources, what budget we have. And no matter how professional is the doctor, how many years he has been in the industry, he should work with the resources. And if we take a hospital where several thousand patients are at a year, how should a doctor, a clinician, a master nurse, how can they manage to count all the available resources or plan these resources, for example, in a year? How can they budget it? So that's the way where math or artificial intelligence, I would call this machines. Where machines beat humans, absolutely. Because even for one disease that we worked with OncoBudget is a project. It's a tool that dramatically increases the survival of cancer patients based on constraints of the budget and the oncological profile. So, for example, for melanoma, you need to have at least 12 groups and at least 11 medications to cure. So in the mass, it will be like what is the result of 12 in power of 11? The result of 12 in power of 11 is more than 743 billion combinations. It is just for one melanoma. And in oncology centers, they work with several. For example, in OncoBudget, we work with 4 diseases. So it's impossible to calculate these personally or with your loved one Excel. So for these things, you need a kind of an engine, and that's what we did. And it works perfectly, and it works with a 10% survival rate. So I believe that for these systems, for something like that, people are becoming not doctors, but helpers, machines, robots that input the data in the correct way, and if they do it correctly, they get the best calculations. Sorry, clinicians. Thank you.
Thanks, Max. So yeah, I think there's some of those things you said there are really important in terms of, as from resource, we are, there is a ceiling. From a staffing perspective, there is a ceiling. From a budget, there is almost certainly a ceiling. But actually, we are starting to learn where the ceiling of AI actually starts or ends, or does it ever end? And actually handling such large data sets is quite clearly a use case for AI to be able to do something that would take us a lot longer as humans. But as we said before, we need to trust it. There needs to be accountability. And I think this is where we start to formulate how we can work together as both machine and human. I think that's interesting because I think it still is around this support, this raft of actually making care be more efficient or, coming to a diagnosis faster, in your case, oncology. In terms of care provision, and I'm going to come to Thomas and Abiola for this one, how do we actually use AI to bring them closer together? How do we see clinicians working together with the use of AI? How do we see clinicians or healthcare providers and patients working together with the use of AI? I'm going to come to Abiola first, specifically around your project as well and how you've worked with AI.
Thank you. So with my care assistant, it was born about the fact that my aunt died of breast cancer, and that was and before then, the challenge we had was trying to get access to, support workers or caregivers to help, to support her while every other person go on with their daily lives. So it was more like a burden, for the family. And we couldn't achieve this at that time. And working in the UK actually exposed to me that I've seen people with breast cancer that live up to 20 years. But she had hers and she died within 5 years, so it was really sad. Now, the problem again was that, fine, we had clinicians that were managing her, but the support was missing. So with my care assistant, we thought that to help clients and even clinicians to make the work easier, we're going to set up this, this software whereby clients and caregivers can connect together. So we have the mobile app for the caregivers and then for the client. So you put in your data, you have access to care. So you can be in location A or location Z, but you can get care within your own geographical location. So that way you have that support. At the same time, it's helping clinicians and also reducing readmission rates in the hospital because you have that support with you. It's a lack of support that leads to clients revisiting, the hospital all the time. At the same time, incurring more costs and then, leading to low productivity and low quality of life. So with that support, we're helping the clients, to have a good quality of life. At the same time, reducing readmission rate and helping clinicians to focus more on important things.
Brilliant. It sounds like a great project. I think, the thing is, what we're looking at is connecting humans through the use of AI, but the AI isn't intervening, it's only complementing. I think that complementary care is really important. Thomas, you mentioned about clinicians working, or healthcare providers working together with the use of AI. What were your experiences with this?
If you look at the history a bit, what you were saying, 150 years ago, there was basically one physician for everything. There was one GP taking care of everything because medical knowledge was very limited at that time. And today, medical knowledge, especially with the rise of data, healthcare data, is growing exponentially. So what were we doing? We are specializing always more. You have oncologists now, and even in oncology, you have lung specialists, and even in lung, you have some. And the more it goes, at some point, the system cannot continue like that. You can't have like a GP at the beginning and the super specialist at the end, and 10 people in between. So AI, in a way, is addressing that, and that's the solution to this. The big question is, where do we start? Do we put a super GP that basically like a physician plus AI that takes care of everything? That might be, I think, the end scenario, but what we're seeing right now is you start with the specialization. So you will start with the radiologist, and then the radiologist plus AI, and then you will do that with all the specialization. At some point, that's a bit, I think, the end scenario. You will go upstream, and I think the scenario where you have the super GP supported by AI and no specialization anymore is a scenario that might happen. I think maybe it will stop in between, but that's big, like the evolution. And just one last point on, because we have nurses and physicians, I think there's also this dynamic. Right now, if you think about physician, the value chain of a physician is basically diagnosis, treatment decision, and treatment monitoring. And this is quite, I would say, easily, but that's something that can be easily replicable by AI. While nurses, what they are doing, this empathic and this relationship with the patient, people have emotions, I heard in the previous panel, it's not easily replicable by AI. So you will have a kind of structural shift, I think, in the relationship between nurses and physicians. The physicians are right now more the leaders, at least in Germany and France, and the nurses, might have more power, and there will be a rebalance of power between the two, with nurses having much more power because they have this empathy that is not easily replicable by AI.
Thank you both. I think that's really interesting. I think emotion is really important with this because that is something that is irreplaceable. It's something that AI just can try and learn, but I don't think it ever will. I think, and that's just my opinion, I think, Giles, we're both clinicians by background, and we've both taken the plunge into the technical world. What are your thoughts on that in terms of how we work with AI and tech in general, and how they can complement one another?
So I think that ties in a lot with the emotional component that we mentioned before is missing from tech. And it's always going to be limited by how we as humans create that tech. But also thinking, well, why are emotions even important at any point on someone's journey with a product or service, which can then help decide actually, is it the tech that has the influence or the greatest power to impact that emotion, or is it the human being? So building on teachings that Don Norman has done. Don Norman's like the godfather of user experience design. And his book, The Design of Everyday Things, is like the Bible that all UX designers read when you start out in this field. Now, he talks about in his book, Emotional Design, about these 3 levels of emotional design, where this can really be triggered by human or by tech, but it depends on the actual given situation. But that first level of design is the visceral reaction. So that first reaction where you see a product or you interact with a person and it instills trust, but it could also instill fear. It could instill a desire to bring about change. So you're seeing loads of people enjoying themselves on the beach when you're at a conference. It's like, you know what, I've got that visceral reaction to maybe go and join them on the beach. But then the next level is that behavioral reaction where you're actually having an experience and you're like, is this actually useful? Is this actually possible to complete the task with it? So I'm like, well, right now, I don't have any swimming trunks. It's not really practical for me to go to the beach unless I'm naked. I'm not willing to do that. So you got to think about what is what you're dealing with now actually going to be useful? Even if it seems like a good idea, seems appropriate to go ahead with the emotion that you get from that visceral reaction, do you have what it takes? Do you have the resources? Is the tech or the human being you're dealing with going to actually support that emotion or not? And then that last level is the reflective level. So you've actually now gone ahead and gone to that conference and I'm like, well, this actually has changed my life. Hopefully that's what some people in the audience are like. Listening to Giles has changed their life. Maybe, I don't know. But the point being is that you have that experience and you reflect afterwards on how has that impacted you. Has it the technology or was it the human? And actually it could be that reflective level that says, I see how this digital technology, this AI solution has improved my health. Therefore, you know what? I'm going to use it again. But you want to make sure that you've got someone to that point where they can reflect. You have to have a positive visceral reaction and a positive behavioral one for you to hopefully eventually get a positive reflective one. It's not always as simple as that, but that's generally how we need to think. If we keep this in mind when we're training our clinicians, but also designing our tools and seeing how AI fits into the solutions we're making, that's when we're going to start seeing humans and tech playing nice together.
Where do we buy your book? But no, I think that's a great point, Giles, and I think that's a nice kind of ending point with this, really, because I think you are right. I mean, I've certainly noticed in this industry that you will get caught out if you push a solution that you think is going to, change the way that we do things. If it's not tried and tested, if it's not trusted, if there's no accountability, you will get caught out. Because, clinicians, healthcare providers, we're here to provide care, and we need to do that as safely as possible. And so there is a place for artificial intelligence, absolutely, and we've got some great cases of that as well. And but I think what we've identified in this panel today is that there's a balance, and I think striking the balance is actually the most valuable part of this collaboration that we're discussing here today. And I don't think it is a case of versus. I think it very much is about that harmony and how you work with one another, but doing it safely, doing it authentically, and actually doing it the right way is going to make it a much better collaboration, a much safer collaboration, and ultimately the best outcome for all the stakeholders that we've kind of discussed there. So 10 seconds over. I'd like to wrap up there. I'd like to thank all of our panelists. Please give them a round of applause. Amazing insights. And thank you, and thanks from me as well. Please feel free to catch them and discuss with them, because, like I say, you can debate for the rest of the day about this topic. It's absolutely hot, but it's important that we do, because I think the more we do that, the more we can sort of come to that agreement of how are we going to work together as humans and machine. Thank you.